Good morning. Welcome to the third plenary session. I hope you're enjoying the conference. We have another jam-packed day of symposia and workshops, and then we hope to see you on the dance floor tonight. We've seen and heard some amazing basic and clinical science over the last few days. It's exciting to witness the dramatic impact of this science on the lives of people with cystic fibrosis, and to imagine the future that we together have the opportunity to create. Now, today's plenary is going to bring us back to the reality of CF in the present. But before we get to this morning's presentation, we have a little business to conduct. Although some of this business is specific to care centers in the U.S., I hope my comments will strike a chord with care center staff from around the world. As you know, CF care centers are the places where people with CF and their families come together with multidisciplinary teams to deal with this challenging disease, and where a treatment plan is developed and put into action, where deep and lasting relationships are forged that help sustain people with CF and their families and enrich the lives of the center staff dedicated to their care. Care centers are also where clinical research teams do the tedious prep work to initiate clinical trials, and where people with CF enroll in those trials. In other words, care centers are where individual decisions and sacrifices are made every day to help advance the therapies that will hopefully ultimately transform the lives of those with this disease. So to the care center and the care center teams from around the world, we thank you for all you do on behalf of people with CF and their families. So this morning, it's my honor and privilege to publicly recognize several CF centers in the U.S. for their outstanding work. In 2008, the CF Foundation created the Quality Care Awards, which are given annually to those centers demonstrating a sustained commitment to quality improvement that has led to tangible results. 22 care centers were considered for the award this year, those that underwent a site visit from their peers on the center committee over the previous year. So I'm proud to announce that the 2012 Quality Care Awards go to the following care centers: the Children's Hospital of Oakland, the Medical University of South Carolina, Dell Children's Medical Center of Central Texas, and the University of Texas Southwestern at Austin, the University of Texas Health Sciences Center at Tyler. Would you please join me in a round of applause in recognition of their outstanding work? Now I'd like to introduce my friend and colleague, Rich Mattingly, Executive Vice President and Chief Operating Officer at the Foundation. Thanks in large part to his steadfast leadership, the medical and fundraising arms of the Foundation continue to work closely together to achieve our mission. That collaborative spirit has also grown at many of our centers and the local chapters around the country. Rich would like to recognize several care centers that have gone above and beyond the call of duty with their local chapter to support our mission. Rich.
Good morning. My message this morning, albeit brief, is nonetheless very, very important, because we want to say thank you on behalf of all of us at the Foundation to all of the people that are a part of the center teams that work collaboratively with chapters across this country and volunteers in raising the dollars to pay for the care and the science that's changing the face of this disease. We've never had a year where teamwork was more important than in 2012. And the stories that I've heard throughout these halls over the last few days of people working together are extraordinary. So thank you. Thank you very, very much to each of you and to the great teams in the care programs from coast to coast and border to border. Annually, we recognize through a process where chapters nominate care centers, and an independent committee reviews those nominations and makes the following recommendations. For partnership awards, between the chapter and the care center, and innovation. This year, the awards go to Johns Hopkins University, Children's Hospital of Los Angeles, Children's Hospital of Alabama and the University of Alabama at Birmingham, Connecticut Children's Medical Center and Hartford Hospital, SUNY Upstate Medical University. We also have 2 awards given annually for innovation working with chapters, and this year's awards go to Ann and Robert H. Lurie Children's Hospital of Chicago and the University of Southern California Keck School of Medicine. Thank you very, very much.
Thanks, Rich. Next, we'd like to recognize the many young investigators who have joined our ranks. We count on you to take us to new heights in the basic and clinical sciences. The selection committee had a difficult job choosing from the many high-quality abstracts this year. They finally agreed on this year's Young Investigator Awards, which go to Kevin Pisoter, University of Washington in Seattle, and Nicole McNear, Nicole McNear, Yale University in New Haven, Connecticut. Please give them a round of applause. Next, I'd like to recognize our meeting staff. We would not be enjoying this great conference without their expertise and many late nights in the weeks leading up to the conference. Not shown on this slide, because I couldn't fit all their names, are the many other individuals from IT, operations, medical department, and on that have contributed at this year's conference. Please give Cynthia and her amazing team a round of applause for another superb conference. Now I have the pleasure of introducing this morning's speaker. It has become increasingly clear to us at the CF Foundation that adherence to the medical regimen is a very important and a very challenging problem. Indeed, some have referred to adherence as the final hurdle in the race to cure and control CF. The CF Foundation has committed to do more to address this issue. We've formed a multidisciplinary working group to craft a strategic plan, and we will be moving quickly to implement that plan. This morning's speaker is one of the key leaders in that working group. She received her PhD in clinical psychology from Case Western University and then completed postdoctoral training in health psychology at Johns Hopkins. Recognizing a rising star when they see one, Hopkins invited her to join the faculty, where she currently serves as an associate professor of medicine. She is the principal investigator or co-principal investigator on several NIH and foundation-sponsored intervention trials on improving adherence and health outcomes. She and Dr. Quintner are co-principal investigators on the eye care study, jointly sponsored by Genentech, Novartis, and the CF Foundation. Known throughout the CF community for her dedication to improving the lives of those with CF, our speaker brings that rare combination of expertise and passion to all that she does. We're fortunate that CF is one of her focused areas of research, and we're honored she's here with us today to share insights from her rich experience. Please join me in giving Dr. Kristen Reichert a warm welcome to the podium.
Okay, I passed the first hurdle. I made it up the steps. It's going to be a good day. Okay, so thank you very much to the foundation and to the programming committee for inviting me to speak today. It's a great honor. And these are my disclosures. I have a little bit of consulting and grant money to work on adherence. And I want us to start right now by thinking about a time in the future where we've done everything that we talked about in the first plenary. We've developed the targeted drugs to attack every defect that for each and every patient with CF And so now they have the perfect drug. And I want you to ask yourself, is our job done? And the answer is no, it's not done, because we know even when faced with a life-threatening illness, people for a whole host of reasons still cannot follow and have challenges facing completing their treatment adherence. And so there's a lot of work for us to do. And all the other previous plenaries had great graphics and pictures of what happens at the cellular level. I don't have that, but what I do have is I have people. And so I invited several people with CF to speak with us about the challenges they face each and every day in following their regimen and how they stay motivated. At the top is Megan and her mother. She is 15 years old, and she's had several hospitalizations this year for exacerbations. At the bottom left is Chase. He is in his early 20s. He just graduated from college and is started his first job. And as you can see, we interviewed him while he was hospitalized for an exacerbation. On the right is Catherine. She's in her mid-20s. She works full-time. She had a hospitalization back in April for an exacerbation. She and her fiance moved into their very first house a couple of weeks ago, and 1 week from today, she'll be getting married. But what they have in common, beyond having CF, is that they've had challenges in adherence, and that's led to hospitalizations. And they're first going to get us going in thinking about this issue by talking about the experience of being in the hospital.
I know what to expect when I come in here, and I know that coming in here is going to take a lot away from my daily life activities like work and school. And it's a bummer to be in here. I mean, I know I'm going to feel better as I come out, but it's just the whole idea of coming in here keeps me from wanting to not do my medication.
It's very, very difficult. For one, I usually stay with my daughter. My husband runs back and forth after work to try to come up and give me a break at the hospital with her. It's just very difficult trying to manage myself working and my husband working and going back and forth up to the hospital.
When I'm in the hospital, I just feel like I just want to stay in bed all day and sleep.
It's a roller coaster because as much as I'm more the caretaker for Megan, so I kind of hold it in and it bottles up until I really break because I'm the one who controls all our medicines. I keep her up on her schedule. It's difficult. It's difficult being the strong one and having to deal with everything. And as good as my husband is, I don't think he likes to think about the future for Megan with cystic fibrosis. And I try to think of it as we have to deal with it so she has a future.
I was hospitalized in April, and before that, I had been fairly compliant, but I think I got to a point where my years of non-compliance caught up with me, and I needed, extra help. And so that was the first time I'd been hospitalized since having a job and living on my own, and it was a wake-up call to how difficult it would be to incorporate something like that on a daily basis into a working adult life. And it wasn't a fun experience, so I think that really made me more motivated.
So hospitalizations are clearly take their toll emotionally, physically, across the board for the entire family. So it is really imperative for us to do whatever we can to help prevent these hospitalizations and improve quality of life. I'm going to start today making sure we're all on the same page about how severe a problem non-adherence is, both in terms of prevalence and the impact on health. And there's always a few myths that I hear out there, and so I want to make sure we understand who is and who is not at risk for non-adherence. So I'm going to start first by talking about pulmonary medications. And this is not because adherence to nutrition and airway clearance aren't important. They're clearly incredibly important. There's just good solid data on medications. And the issues that affect adherence to medications also affect adherence to nutrition and airway clearance. So it does generalize. This is a study we did with a large claims database where we found over 3,000 people with CF. And we took their pharmacy refill data to calculate adherence. And I'm going to take a moment here to tell you a bit about how we calculated adherence using pharmacy refill records, because that's the data I'll be showing you throughout today's talk. So when you are prescribed a new medication, you go to the pharmacy, you pick up the medication, and when the medication runs out, you go back to the pharmacy. So if I'm dispensed 30 days of medication, but I don't come back to the pharmacy to get my next refill for 60 days, clearly I've only had enough medication at home that I could take it on 50% of the days. And that's called the medication possession ratio, and that's the data I'll be showing you today. So this is the adherence for each medication. We have azithromycin, Dornase alpha, saline, and the inhaled antibiotics. And the first thing that should become very clear is that adherence for each and every drug ranges from 0 to 100, but that the median hovers around 30 to 60% for each drug. So the first myth I want to address is that we often think, oh, everybody takes their azithromycin because it's just a pill. And what you can clearly see here is non-adherence to azithromycin is just as common as any other drug that's there, even though the perception is that it's easier to take. For some reason, it doesn't get taken as much either. So the other thing I want to point out is this composite medication score. And we developed a composite by taking the average of the MPRs for all the other drugs and averaging them together to get a single adherence score. And this has two very big advantages. First, it lets us take in the totality of the regimen that's prescribed and understand how that affects health. But also, it gives us the statistical power because every participant can be included in every analysis. The other myth I want to address is that we often talk about it's just adolescents who are non-adherent. And this data clearly shows that yes, children have very high adherence, or the highest adherence, and absolutely it does decrease in adolescence, but it continues to go down during people's 20s, so that it is a problem both for our pediatric colleagues as well as our adult colleagues. And when you see it coming back up in the 36 plus, remember that this is cross-sectional data, so it's possible that adherence goes up because it's a survivor effect or the influence of late diagnoses individuals. So we do need to start understanding how adherence changes over time doing longitudinal studies. The other thing we often talk about is regimen complexity, so that the common lore out there is that if the regimen is more complex, adherence will be lower. And when it comes to the pulmonary medications in CF, we actually see the complete opposite effect, with adherence being lower when they're only prescribed one medication and going up as they're prescribed more pulmonary medications. And there's a couple theories I have for why this might be. I think once you're prescribed the first medication, your regimen is already quite complex. You're already doing nutrition and airway clearance, which is not taken into account here. So there might be a threshold effect for how much burden there is until it affects adherence. The other thing is that in these sorts of claims data, we don't have illness severity. And the number of pulmonary meds prescribed might be a proxy for illness severity, and hopefully adherence increases as someone becomes sicker. But my third hypothesis, which I think is probably the accurate one, is that CF care centers are very patient-centered. And I hear time and time again when they recognize that someone's not following the regimen they're already prescribed, we're quite hesitant to prescribe a medication if we can avoid it. So I think we're already accounting for regimen complexity by not prescribing medications, and that's why we see this association. The one thing I don't want you to take away from today is don't add a medication thinking it will make somebody more adherent. So we know adherence is a problem, but in terms of they're not taking it, but does it really matter for one's health? And in a study we did, we had 100 individuals. We calculated their adherence, and then we looked at medical records for how many courses of IVs they had. And what we found was adherence did indeed predict having exacerbation, such that non-adherence predicted having one or more. It didn't predict having 2, 3, 4, 5, because I think illness severity jumps in there. But it did predict the difference between having 0 or 1 or more. So there's probably a significant proportion of people out there who could be avoiding a hospitalization, which we clearly know is unpleasant, if adherence could be higher. And the other thing I want to point out is that a common cut point between calling someone adherent and non-adherent is 80%. And what you can see here is that those who had an exacerbation, very few of them took more than 80% of the medication. This also affects lung function. Again, using the three-group cut point at this point is 80% or higher, 50 to 80%, or below 50% adherent. And right off the bat, you can see there's a big difference between those who take 80% or more and those who take less than 50%. And this is about a 15% difference in FEV1% predicted. I think we would all agree that that's kind of an important difference. And they're very different even at baseline. And this probably reflects the fact that we know that the best predictor of future behavior is past behavior. So this could be the result of several years of adherence patterns over time. And the other thing to point out is those who took 80% or more did not have a decline in lung function over 1 year. So that also is something that we would like to strive for, is to not lose lung function. So clearly adherence matters to those outcomes that we focus on in our clinical trials, exacerbations and lung function. But it also affects healthcare utilization and costs. And this is a study that's going to be presented at Symposium 18 this morning after the plenary. And again, we split it into three groups: greater than 80%, 50 to 80%, and less than 50%. And looking just at inpatient hospitalization costs, you see that having higher adherence resulted in lower costs than the other groups. And when you get to the less than 50%, you can see that it's almost $12,000 more per year if you take less than 50% of your medications. If we translate this to the whole CF population, if 50% of the CF population takes less than 50% of their medications, in a single year, it's more than $150 million in inpatient costs that perhaps we could avoid. So clearly there's a health benefit and a public health implication of non-adherence. So if we know that adherence is a problem, and patients absolutely want to do whatever they can to avoid going to the hospital because it takes such an emotional toll, why is adherence so challenging? Why is it so hard to get therapies done each and every day? And we're going to refer back to our experts now to hear what they have to say.
The things in life that make it challenging to follow my regimen would be just everyday activities, finding the time to manage work and a social life and taking care of things at home. It's hard to come home after working 8 or 9 hours and then try to fix a meal and, run some errands or go to the gym and then do my meds too. Or, go out with friends and come home at 9 and then try to get some medication done too.
It's hard because I'm trying to do homework in school and then do my brain treatments and then my vest, and also trying to hang out with my friends on the exact same day. I gotta plan out times for when I do each activity.
It was basically what I figured was just from work and school and everything, finishing up with school and starting a new job. It took a lot of extra time away that I usually did my medications with, and I'm usually good about doing them.
The hardest part is trying to remember them. I'm always forgetting them and then trying to do them as soon as possible.
Motivating other people is tough. I work with people, so I gotta find different ways every day. I feel the same way most of the time. I feel like I'm wasting time sometimes. There will be certain medications that I'll do that I don't feel doing anything for me like other ones will, but I know they're doing something, and that's what I would say they'd have to keep telling them. It's doing something even though you don't feel it, because when you don't do that one piece, it throws everything else off.
As Megan gets older, trying to get her to be more independent has been a struggle, because I don't want her skipping breathing treatments or physical therapy, and trying to get her to recognize the consequences if you do.
Sometimes, depending on the mood I am, I just don't feel like doing them, but then again, I know I have to.
So there are obviously many challenges, but just how complicated can this be? And so there was a recent publication by Modi and colleagues in pediatrics which presented a model. And when I say it's adapted, I adapted it by taking out about half the things that affect adherence, because you wouldn't be able to read the slide if I put it all in there. And it starts with, there's 4 domains. The first one is individual factors. So we already know that age is a factor. It's nothing we can actually change, though. But there are other things, such as knowledge. Do we know what we're supposed to do? Mental health, like Megan said, when she's in a bad mood or when people are feeling down or depressed, it's very hard to suck it up and take your medications. Health beliefs and perceptions. Chase told us about how if he doesn't think the medication is working, he doesn't want to take it. But there's also family factors. We don't live in a bubble by ourselves. We live with families. And their individual factors affect one's adherence as well as other issues. So a single-parent family versus a two-parent family. Parenting is stressful and it's hard to get it all done if you're the only one there. There's relationship qualities, the level of support you get from someone in your family. Catherine told me about her fiance would set up the medications for her and sit with her as she did it. And we hear that from many patients, that level of support is very encouraging and helpful when it comes to adherence. But there's also conflict. If you're having a conflictual relationship, it's also harder to take your medications. Just think of the parents and teens conflict and how that might affect behavior. And as Megan's mom talked about, involvement in care. She's trying to help Megan become more independent, but that means she's less involved in care, and that's taking its toll on adherence as well. But we, the healthcare centers, also influence adherence, primarily through how we communicate. Are we giving positive feedback? Are we giving good health feedback? Are we lecturing and making patients feel bad? Are we including our patients in decision-making about their care plan? All these things affect adherence. And then the community aspects is what our experts told us a lot about, how work and school all affect taking our medications just through the stress and the other deadlines that we have on a given day, but also peer support. You know, we have a lot of people tell us that when I come home from the bars, I'm not even brushing my teeth, no less doing airway clearance or sitting on a nebulizer. So there's lots of things that all combine together to make one person's level of adherence. And each factor, each one of these affects each person differently, and it changes over time. So each of these factors, as relationships change, adherence also changes. So it becomes quite challenging. So I'm going to focus in on 3 of these factors that are things that I think in the care center we can address during that clinic visit. And the first will be knowledge, then mental health problems, and then health beliefs. And I'm going to illustrate this using data from the BALANCE study. The BALANCE study is an NIH trial that just completed enrollment and baseline in the summer. And we enrolled 125 individuals aged 16 and up. And we did an extensive psychosocial baseline assessment and got pharmacy records, and then we randomized them. And I'll be showing you some of the baseline data today. So I'm going to start with knowledge, because when we identify adherence in care centers, non-adherence in care centers, the very first thing we do is provide education. And that's clearly important, but what you'll see here is that knowledge was not a predictor of whether someone was adherent or not. You can see that the medians are actually quite close. So just because you know what to do doesn't mean you're going to go home and do it. But there is a level of knowledge that is necessary, and you can see that those with particularly low knowledge do fall into that non-adherent group. And to bring this point home a little further, this is an intervention study that focused on improving nutrition knowledge in order to improve weight gain. And they were very successful in improving CF-specific nutritional knowledge. The intervention group in yellow is definitely higher after the intervention, and that knowledge sustained over a follow-up period. But over here you can see that there's absolutely no difference in weight gain. So just because they understood about how to boost calories, it didn't translate into behavior. So knowledge is a necessary piece of the pie, but not the only thing that we should be doing. And I'd be remiss as a psychologist to not address depression. Depression is common in the general population. It's common, and it's more common in chronic illnesses. And the TIDE study showed this to us. The TIDE study was an international effort to screen individuals with CF for depression and anxiety. And it was led by Alexandra Quintner and Michael Schechter. And in the US, we screened over 1,000 individuals. And what we found is that 1 in 5 individuals screened positive for depression. So depression is a major comorbidity that goes along with CF that in and of its own right should be treated, but it also affects adherence and therefore other health outcomes as well. So this is the data from the BALANCE study that shows that those who were non-adherent were much more likely to screen positive for depression. We see this time and time again across illnesses, and therefore we need to address adherence. So we need to make sure that we're screening for depression in our clinics and that the social worker is engaged in helping our patients deal with the issue and making sure that we have our connections to our mental health community, because not all these issues can be addressed in a very brief clinic visit. So we do have to have those partnerships to make sure that we are addressing this serious comorbidity. Now, health beliefs. There's a whole bunch of health beliefs I could talk about. I actually had about 3 or 4 more slides, but I cut it down to 3 main ones that I think can be addressed in a clinic visit. The first is importance. And the type of question we ask is, on a scale of 1 to 10, how important do you think it is to take your medications every day, when you don't feel well, and when you feel fine? And here's our data. So both groups clearly have high importance. Again, our educational message that medications make a difference has gotten through. But what you can see is those who were non-adherent had lower sense of importance, that maybe it's not quite so important. Similarly, there's motivation. On a scale of 1 to 10, how motivated are you to take your medications every day, when you don't feel well, when you feel fine? And a similar pattern shows up. While it's skewed towards people saying they're motivated, those who were non-adherent were less motivated. They gave less motivating scores, and particularly some very low ones. So if someone doesn't want to do something, they're probably not going to do it. And self-efficacy is the third group. And that's self-efficacy is the confidence that you can do a behavior even faced with other challenges. So on a scale of 1 to 10, how confident are you that you can take your medications when? And we developed a measure that had 17 different barriers that people with CF had told us that they encounter. Things like when I'm tired, when I'm busy with work or school, when I'm with my friends, when there are people in the room that I don't know quite so well. And that's a very strong predictor of adherence. Those who are non-adherent are less confident that they can overcome the barriers that they face. And so if you assess these 3 components during a clinic visit, it helps tell you where you need to focus your efforts. So using Chase as an example, he said he's not sure the medications make a difference. So perhaps he's feeling a low sense of importance to take that medication. So what information might we be able to share with him so that he understands or can see why it's important for his health? But probably more importantly for him, as he's going through the transition to work, how can we help build his self-efficacy? So if he's asked to take on another shift at work, how does he make sure he's taking his medications as well? His routine has changed, and we have to help him develop a new routine and new strategies. So this sort of leads into our discussion of what can we do to support adherence. And we're going to start again back with our experts talking about what motivates them to follow their regimen when it's difficult.
I think the thing that motivates me the most to do my treatments is seeing the progress and seeing it work. Seeing my numbers either go up or at least stay where they are rather than decrease really helps me want to keep doing it. And when I feel better too, I can feel a difference from when I do them versus when I don't.
I think of it as the more I keep doing my brain treatments, the more I'll get healthier and the more I will live longer.
Do you want to cause all this extra work for yourself that you really don't need to? And also that I know it's going to be more work no matter what. So it's easier just to put in the work now and get, the basic stuff done rather than go through all this long process of, being out of work and school, staying in the hospital for up to a week, and then taking IVs home with you and doing them for 2 weeks. So it's just basically the whole thing of you don't want to come here.
I think the things that help someone stay compliant is, first of all, not making them feel bad if they're not. Life happens. There are going to be times where you're not compliant, and it doesn't help to just feel down about it. I think you need to stay motivated and know that you can get back on track.
Make sure you have a good support group around you. Don't associate with friends that are going to tear you down or, put you in harmful situations. Make sure you have really good, close-knit friends.
And the other big thing would be to just take it day by day. It's really overwhelming to look at. I have to do this stuff every day for the rest of my life. That just makes you freeze and want to give up. So I just take it day by day. Like, well, today I have to do this, and I can do it at this time, and then move on and go from there.
So it should come as no surprise that since the factors that contribute to non-adherence are complex and multi-leveled, that interventions that are efficacious are also multi-component and often complex. And systematic reviews and meta-analyses have shown us that education alone, interventions that only provide education, are not efficacious. Absolutely every intervention has to include education, but they need other aspects. And these are all the different factors that have been components of different interventions. There is no silver bullet right now, but we do know that these factors, when combined, do help many people. And the ones on the left in the yellow are things that I think we can do in clinic. For example, they've asked for health and feedback. When I feel better, I want to keep doing it. I need reminders. How do I remember to do this? Some help figuring out where to do treatments when I'm busy. And the ones on the right, in the blue bullets, are things that are more complicated. They take more time. They take more clinical skill, counseling skills. And so those are things that probably do need to be pulled out and separate from a clinic, although they are very important. So we know there's interventions that work. They're just very complex, and we need to find ways to make them simpler and easier to disseminate out through the care centers. And this is just one example. So I'd shown you already that education alone did not improve weight gain. This is the Be in Charge study with Laurie Stark and colleagues. And what they did is, in addition to providing parents with education about how to boost calories, the intervention group also received parent training on how to handle meal times. And if any of you have kids, you know meal times can be chaotic. They're up and down out of their seat, they're refusing to take a bite. So how can we make this a positive experience and reduce the negative behaviors? And the intervention showed that they were able to increase calories after the intervention, so that the skills were there, the parents were able to help their children take in more calories, and that did translate into weight gain post-intervention. What this also shows, though, is that the 24-month follow-up, those gains were not sustained. And this is a next big point, is that our interventions cannot be one and dones. They can't be a quick bolus of attention and then pull it away. It really has to be ongoing and sustainable, because barriers and challenges change. Obviously, 2 years after an intervention with a child, the child is very different and needs different parenting skills in order to manage the behaviors. There are several ongoing trials that results should hopefully be out in the next year or two. The balance study that I've been telling you about is comparing motivational interviewing, so focusing on the motivation side, compared to problem solving, which focuses a little more on the self-efficacy side. So it's more of a comparative effectiveness study. The eye care study that Bruce mentioned is at 18 care centers around the country, and it's comparing the CF My Way intervention that Dr. Quintner developed, which is knowledge and skills of remediation combined with problem solving. And the unique thing is that it's actually done in care centers at regular visits. It's not pull-out research visits. It's done during the regular care visit. And then Dr. Quintner also has the CF Phone, which is a Facebook-type interface for social networking for just individuals with CF, with some education provided as well. And then Dr. Stark is taking her efficacious face-to-face intervention and trying to translate that to a web-based approach so that it can be more disseminable and easier for parents and families to use, because they wouldn't have to come into a clinic. So there's many things in the works, but our toolbox is still not completely full. There's more things we can do and develop to help our patients and help it make it a little easier for us as well. And there's two areas I really think we need to focus in on. First, we need to accurately identify who's non-adherent, and you'll see in the next slide why that's critical. But we also, as I said, want to explore ways to make interventions easier and simpler for parents, families, children, and us, the care teams. So why do we need to more accurately measure adherence? Isn't just asking the patient enough? Isn't just my clinical impression sufficient? And this is one of my absolute favorite studies by Daniels. At the bottom on the x-axis is objective adherence. So she had a device that would date and timestamp when an inhaled antibiotic was taken. And then she asked patients to report their adherence and then plotted them. The red line is perfect agreement. And what you can see here is there's not perfect agreement. When patients tell you they're doing a good job with their adherence, so 80% or higher, there's complete random scatter. So when someone tells you they're doing a good job with their medications, you really have no clue what they're doing at home. Which, I know, oh no, what do we do? what we have is this empty half of the plot, which is completely empty. And this makes me happy, because this tells me that no one ever says they do less than they do. We all take credit for good things. So if someone says they're only taking half their medication, they're really only taking half their medication and probably less. But once we know there's non-adherence and someone's saying, I don't get to it all the time, sometimes I miss, that's the point we can intervene. So clinically, we don't always need a precise measure. So what about clinician report? So Daniel's asked everybody on the care team to rate adherence, and the physiotherapist was the most accurate. And what you can see here is complete random scatter. Physicians, clinicians, all healthcare providers, I know we all think we know our patients really well, but we are no better than chance at identifying who is and who is not taking their medications. And this has huge clinical implications. And let's take this patient, for example. This person is taking almost 100% of their medications. They're rocking it, they're doing a great job, but the care provider thinks they're only taking about 50%. So now envision the conversation in the clinic. You know, Joe, you really got to do a little more of your medications, you got to try a little harder to get a few more of those in, really stick to it. And Joe is saying, I'm doing almost everything, there's no way I can do one more thing. Maybe it just doesn't make a difference. Maybe it doesn't matter if I take my medication. So the exact conversation and interaction you were hoping would increase adherence because you thought they were 50% might actually decrease adherence. Similarly, those who are taking nothing, but the care provider thinks they're doing a pretty darn good job, imagine the conversation there. You're doing a great job, keep up the good work. It's really making a difference. Well, you just told me I don't need to do anything. So you have now just convinced me that my medications are not worth it and I don't have to bother, why put the effort in? So it's really, really key for us to have a good measure of adherence. And if you ask me which one I don't want your report, I'm sorry. I want to go straight to the patient and ask them because at least I know the direction of the bias. But ultimately what I really want is a subjective number at the bottom so that we don't have to do the dance of trying to figure out who is or isn't or how adherent they are. We'll just know and we can have the conversation about how to address the problem rather than having to figure out if there is a problem. And there are many different ways coming that we can do these. There are electronic devices being developed. This is the iNeb, which was used in the Daniel study. Right now it's only available in Europe, but many of those clinics are using it with every patient and using that data to help make treatment decisions. Prescribing is what I use in my research studies, and you all are going to have access to this. If you don't already, it's coming soon because you'll be using e-prescribing, and in your new electronic medical health records, many are incorporating access to pharmacy refill records. So you can just take a look and see what's going on rather than having to guess. But ultimately what I really want is this scenario down here, and this is for a weight loss scenario, which is not what we need in CF, but this is what I found. This is an NFC activity sensor, which just means you wear it and it records your activities and it just sends it down to the computer server. No other behaviors need to be done. And then there's a Bluetooth scale that when you step on it, it also sends it down to the server, and it puts it all together and it gives a personalized health feedback. That would be the ultimate, to show people that it makes a difference if they're taking their medications or not, and to say, you know, you slipped below the 80%, let's figure out a way we can do more. And you get lots of data when you do this. Imagine every time someone takes medications or a step, you get a row of data, and that can be overwhelming. But we can synthesize this into very useful pieces of information that can be used clinically. So here's an NPR for each drug, calculated over time. You can see adherence was dropping instead of going up, so we're not liking the direction it's going. And this young woman had 4 exacerbations. And so the conversation doesn't have to be, are you taking your medications or not? It's, you know, we know that if you take at least 80% of medications, most people can stay out of the hospital. You've had a really rough year in the hospital. Let's do what we can. How can I help you? Take your medications more so you can avoid a hospitalization. And so this all comes to leveraging technology. And I'm sure there are many of you that have each and every one of these devices in your hotel room, if not in your bag right now. So there's lots of technology that we can use now that wasn't available in the past to help us design interventions that will be supportive. And we use technology for everything. We use it to get our driving directions. We get it that when we're in a new city, what restaurant should I eat at? Where's the closest pharmacy because I forgot to bring my medications? We use technology in all sorts of ways. So how can we leverage this for health promotion? And if you don't believe me that technology is everywhere, this is by age. How many people have, in the dark blue, a smartphone, the medium blue, a cell phone, and nothing? And the exact age group that we're concerned about adherence, adolescents and young adults, they all have a phone, and most of them have an internet-capable phone. And these numbers increase dramatically every year that Pew assesses this data. And the other great thing is that there's not a racial or economic divide. Those from low income are just as likely, and sometimes more likely, to have these types of devices and use them. So a phone-based intervention or an app-based intervention is certainly something that we can consider. And I'm not the only one to think of this. There's thousands and thousands of apps being developed every day. More and more are pushed out for the iPhone and also for the Droid. The thing is that less than 2% are right now targeting medication adherence, and those are simple reminder systems. And reminders are great, but there's so much more ways we can take advantage of technology. And let's ask our experts of how they would want to take advantage
I
of
know
technology.
there is an app for cell phones that you can use that sends you alerts to do your medication. I have a couple CF friends that use it.
I think the most important thing when it comes to any new apps or new technologies would be not making CF patients do anything else. We already have a long list of things we have to do every day. So if it can be something that is done naturally and without us inputting any more information, that would be helpful. Something to track our progress and keep us motivated. Maybe something that's interactive with the CF community would be helpful too.
We thought even if they had some kind of app to check your PFTs on air. Of course, my daughter thought that was funny because she didn't know how they were going to do that, but I thought that'd be great. Because then you would be able to see how low your PFTs are before you're actually really sick. And to keep an eye on when they're low, you know something's coming and maybe you can increase your physical therapy or be able to call your doctors and let them know, hey, my PFTs are low, maybe I should come in for a visit.
It'd be really cool to have a thing that you could stick on your phone and it just blow into it like a PFT meter or something. I mean, I know that's kind of hard, but it'd be kind of cool though to see that. I'd probably use something like that just to keep up daily, say, hey, I'm down today. What's making me down today?
And maybe if you could keep up a medicine list, updated medicine list on your phone, so you can just show the doctor, scan it under a scanner, and show this is the medicines I'm taking, no allergic reactions.
So obviously our patients want technology. It's appealing to them for many purposes. It would be convenient to have it at their hands. They don't have to come in for visits. So it doesn't matter if they live rural, urban, show up, don't show up. They can do it anytime they want. If they're up at 2 a.m. and they want to do it, go ahead and do it. It's fairly cheap to develop these types of technologies. So I'm going to show you a few of them. So this is the CF notebook. That's mostly a diary function just to log activities. But if you clicked on meds, you could put in your list of medications. So again, this isn't particularly interactive, but if you're normally a notebook type person, you can have this on your phone instead of having the notebook. And so when someone asks a question or says something, you can put it right in there in the appropriate chapter and take it where you go. This one's a little more sophisticated. It's not on the market. If you Google apps, you can find all sorts of things that are coming. But this is going to have reminders, social comparison, comparing you to other people. We all want to be the biggest, the best, the smartest. So am I also the most adherent? And perhaps some incentives with points and rewards and discounts. But this is the one I wanted to show you because two participants asked. So this did not require any additional, all he did was blow into his phone. So this is being developed. And so imagine that you forgot to do your PFTs at home, you're stuck at the red light and you go, oh, I forgot to do it. And then just blow into your phone and you have the data. It's all done, it's with you. And we can use this type of data for personalized feedback. And I'm going to thank my colleague, Dr. Noah Lecton, for sharing this with me because it's a great illustration of how we can use this data to help our patients. So he was doing a study about home spirometry. This woman did it every day, and when she came back, she met with a different physician, and she just started saline. And the physician said, what do you think about it? Yeah, I don't know, maybe it works, maybe it doesn't. So they were kind of decide whether she was going to stick with it or not. And they brought back this chart and said, well, what happened over here? Why did it all of a sudden pop up? She's a nice, organized person. She pulled out her calendar and said, that's the day I started saline. So this person switched from being equivocal to a couple years later when we interviewed her and we asked the question, if you can only have time to do one medication, which one do you do? She says saline. So this is very powerful health feedback that we can use to help motivate patients about the importance of taking medication. And there's opportunities to capitalize on real-time data that I've already shown you, but there's also ways to incorporate behavioral principles that we're just starting to do, and some other apps have started this. So there's rewards. This is my workout app that I use, and on this particular day, I realized I had 15 minutes until they were going to give me a new badge. And so I said, well, I have time to do another 15, so I did some 15 minutes core, and they turned this from gray to yellow. That's the reward I worked an extra 15 minutes for, but we do it. We think we don't work for stickers, but we will. And then we can also do other things like competition. You know, 2 care centers could have a competition who has the better adherence for a particular drug. We could have a altruism. So I'm not doing it for me, but some donor said if we can get enough people meeting a certain mark on their adherence, they'll make a donation to the foundation. We work for these different things. We know this works from video games. Why not take it into account? So social networking is also an opportunity. I can share my workout results with my Facebook and Twitter account, folks. I don't know why they want to know I did some abs, but many people do this. They chart their bike route and they share it. And when you look at the postings, the comments, you go girl, good job, you know, you're Wonder Woman, all these great comments, and that really encourages you to keep doing it. But the greatest thing with this technology, it's dynamic and it's changing, and you can push through updates quickly. You don't have to send out another CD-ROM so someone has new opportunities to use things. And that's important because we get bored pretty easy, and so we need change to keep us motivated. But these are all things in the future, and I know by Saturday morning we're all thinking about what is our take-home thing that I'm going to do different in clinic on Monday morning. So I did want to put a few of those out there. First, you do want to assess adherence every time, and if you have access to pharmacy records, please use them. But if you don't, ask your patients, which, if any, medications are you taking? And the if any is a really key point because that shows that you're open to the possibility that they might not be taking any of it. But please don't respond with a lecture. As Catherine told us, they already know they're not taking it. If they told you they're not taking it, they know they're not taking it. They don't need to feel worse about it. That's not going to get them up and going. We need to provide education, but we need to do more. And what more we need to do is assess the barriers. What's making it challenging? Don't say, why can't you do it? That's a little a little rude. But what's challenging? What's hard? And then how do we problem solve this with them? How do we help them overcome those barriers? You guys have a wealth of experience knowing what has worked for other people with CF and to be able to share that information. But also don't hesitate to partner with mental health professionals when the behavior and the challenges are beyond what can be handled in just a simple regular clinic visit. So in summary, I think non-adherence is a significant clinical problem. I hope I've convinced you all of that as well. And my title, Where's the App for That?, has 2 meanings. Of course, I wanted to talk about apps, but I also want to point out that there is not a quick fix. It's not as easy as downloading an app to your phone and now you've solved the problem. You can't just say, go use the CF notebook and all's good. But it is an important tool that we can add to our toolbox to help address how complex adherence is. And so in the beginning I asked, if we find the perfect drugs, is our job done? And I think we have to all agree that our job will actually just be beginning. So thank you very much.